morning, good afternoon, good evening. Live from Toronto, this is IFA's Global Café. My name is Bruna Swerts. I'm Director of Communications and Strategy here at IFA, and it is my pleasure to host today's session. Just in terms of housekeeping rules, please be reminded that this session is being recorded. It's also being live streamed through our Facebook channel. You will have access to all the recordings and materials in our webpage. And if you have any questions, please make sure to post them on the chat box. Our moderator will address them later today at the end of the session. We have a very intriguing conversation today about hearing health in later life, and I'll hand it over to my colleague Roxana Barrier to start the session. Roxana, the floor is yours.
Thank you. Thank you very much, Bruna, and good morning, good afternoon, and good evening, everyone. Of course, dependent on your geographic location. As mentioned, welcome to this week's IFA Global Café. My name is Roxana, and I am a project officer here at the IFA, and I'm very pleased to be moderating today's incredible discussion. So this week, I have the true honor and pleasure of introducing Dr. Dalia Tsimpida for the topic of the importance of socioeconomic inequalities on hearing health in later life. Dalia is a lecturer in public health at the University of Liverpool. She has an interdisciplinary background in psychology, audiology, and health policy. Her academic research over the last decade is concerned with the social epidemiology and the public health aspects of hearing loss, focusing on hearing health inequalities. She received the International Society of Audiology Scholarship 2020 for her pioneering research findings on the prevention and early detection of hearing loss in primary care, as well as its potential to maximize the opportunity for healthy and active aging. So extremely exciting to have you with us here today, Dalia, and I now do hand over the floor to you. Thank you.
Thank you very much, Roxana, for the invitation and for such a nice introduction as well. I'm truly honored to be here today with you and with people from all over the world. I have nearly a decade of presence in academia, investigating socioeconomic inequalities in hearing health, but my career trajectory was not linear at all. 20 years ago, that day, you would find me working as an aircraft technician in an occupation which has probably the highest level of occupational noise exposure. Any noise above 85 decibels has the potential to cause hearing damage, especially if the noise exposure is prolonged or frequent. So imagine that working at that environment, where the aircraft engine may produce noise of around 120 decibels, the exposure without ear protection can cause permanent hearing damage in less than 2 minutes. I was studying that time for a bachelor's degree in psychology while working full-time, and I was able to approach this issue through a socioeconomic inequality lens. I was thinking that there are many things we can actually do to preserve, this is the right word, to preserve our hearing during the life course. And that hearing loss may be a result of exposure and not an inevitable result of aging. Imagine that we were 25 years old at that time, and many of my colleagues had already high-frequency sensory neural hearing loss, which is the type of hearing loss that has traditionally been linked with aging. So we were already very young to have this type of hearing loss. After my first degree in psychology, I attended classes to learn the Greek Sign Language, being also motivated because 2 persons of my family had hearing loss. So these courses take around 4 or 5 years to be completed to get the national certification in sign language. And during that period, I met many people, I made many friends with hearing loss, and I saw firsthand the many barriers people with hearing loss face to health, the difficulties in communication with health providers, difficulties in booking an appointment, many things that for a person without hearing loss may seem obvious. For example, to listen to your name being called in a waiting room. I remember I was shocked when one of my friends missed her appointment while she was in the waiting room, waiting for the appointment, just because she was not able to hear her name being called. So I was really shocked, and I decided that I wanted to investigate more these issues and find solutions. So I continued my studies, and I did a master's in health policy and health services research. And after that, I was honored to have been awarded a full PhD studentship, and I moved to the UK to do my PhD in socioeconomic inequalities in hearing health. This is the topic of my today's talk, and I will present very briefly in the next 15-20 minutes what I have learned the last 5 years regarding the importance of socioeconomic inequalities on hearing health in later life. More specifically, I will focus on 3 key areas. First, how socioeconomic inequalities earlier in one's life shape hearing health in later life. Second, the socioeconomic inequalities in the diagnosis of hearing difficulties, which is the secondary prevention. And third, how hearing loss in later life generates and amplifies further the existing socioeconomic inequalities in later life. Starting with how socioeconomic inequalities earlier in one's life shape hearing health in later life. I'm sure you have all heard the term age-related hearing loss. I was the first to challenge this term, arguing that this is a misleading term and not an inclusive term that makes people think that old age is the causal factor for hearing loss. In epidemiology, it is a basic knowledge that correlation does not imply causation. This means that just because 2 things happen in parallel, correlate, this does not necessarily mean that the one causes the other. So although there are several associations between age and hearing loss in studies, the recent data from my research show that age is a less critical factor than previously believed in the etiology of hearing loss, as in fact not all people in later life will develop hearing loss. In data from England, in a recently published study using nationally representative data, I found that only 1 in 3 men and only 1 in 5 women, 50 years old and older, had hearing loss. The surprising thing, though, was that those in a lower socioeconomic position were up to 2 times more likely to have hearing loss. So it looks like that hearing loss in later life is a result of exposure, and hearing health has a social gradient. Social gradient is a term which means that people who are less advantaged have, in terms of socioeconomic position, have worse hearing and shorter lives, consequently, worse health and shorter lives compared with those who are more affluent, more rich people. So I argued that hearing loss in later life might be a result of exposure during the life course, and not, as previously believed, a natural part of the aging process for all people. So in simple words, hearing loss happens when we are getting older, if we have been exposed to harmful factors, and not because we're getting older, for all people. I and my colleagues have proposed a novel theoretical framework to support this argument that a substantial proportion of hearing loss in older adults is preventable by tackling the socioeconomic inequalities in hearing health. Today, more than 460 million people globally have hearing loss. So having a model to understand what we can do earlier in life is important to make a start and develop targeted interventions. I will explain now the several modifiable determinants in several stages across the life course, according to this model, the conceptual model of hearing health inequalities. You will find this later in the resources as the paper that has been published. So starting from childhood, children born to parents from a lower socioeconomic background tend to experience more illness and injuries, and the antibiotic drugs used may affect hearing health, especially in sick babies with a genetic predisposition. In turn, consequences of hearing loss in children may include impairment in language skills and language development because they are not able to hear their voice and other people, and lower educational achievement compared to children with normal hearing. The lower educational status is also related to the lower health literacy, which is a common issue among people of a lower socioeconomic position. That can explain why individuals of a lower socioeconomic position may adopt an unhealthy lifestyle with higher levels of smoking and alcohol consumption, higher body mass index, and lower levels of physical activity, which are all risk factors for hearing loss. As people are getting older, the lower educational level is a predictor of their social inequality in later life, as it limits employment opportunities and relegates people to more poorly paid jobs. Furthermore, low-level manual jobs are usually those with the higher level of occupational noise exposure, which is a recognized factor, risk factor for hearing loss. Occupation and income then may affect the access to hearing health services and hearing aids use due to the financial barriers that affect the help-seeking behavior in people in a lower income and the treatment for hearing loss in most countries. The hearing health inequalities can affect the retirement status of people and the income of older adults. This is because affect the ability to continue working when a person in later life has hearing loss, has not the same employment opportunities, not the same opportunities to advance occupationally. So many people retire early due to hearing loss. This model provided a visual representation of all these mechanisms and, importantly, the way they evolve over time and the interplay between education earlier in life, occupation, income, and wealth, and how inequalities earlier in life cast a long shadow over time during the lifespan. Let's now move to the second point of my argument, which is about the importance of socioeconomic inequalities in secondary prevention, which is the early diagnosis of hearing loss whenever that happens during the life course. So findings from a recent study that I published in the journal JAMA showed that up to a third of older adults with hearing loss in England could be undetected and untreated. Up to a third of older adults. Importantly, the study showed that those belonging to high-risk groups are most likely to remain unrecognized. These are people who face socioeconomic inequalities and adopt an unhealthy lifestyle, because these factors may affect the initiation of help seeking, downgrading hearing as a priority, and the referral process from primary to secondary care for the early diagnosis and early treatment of hearing loss. Lifestyle is important, but talking about lifestyle, we don't mean the individual preferences here. We mean the ways of living that reflect group socioeconomic identities that are not personal choices. If people don't have good choices, if people have many choices that are not good, actually they have no choice. So the lifestyle most of the times has to do not only with behavioral individual factors, but with the wider determinants of health, where people live, what are the resources available, geographical factors, access to money, power, and resources that have people, or if they don't have those resources. So for many people, there are significant delays in the process of the early diagnosis for reasons that have to do with structural inequalities and not with individual preferences or stigma, for example. For example, they may be system-level factors that don't give the opportunity, the equal opportunity to people to have access to accessible hearing care. Hearing screening is not available at the moment, and many people will downgrade hearing loss as a health priority and may not be able to pay privately, or may not be able to have access to hearing health services. Recently, the WHO published the guidelines to member states to give the guidance and technical guidelines for implementation of universal hearing screening. So hopefully in the next year, we will have advances in this area, and many people will have equal access to health services. Let's now move into the third point of my argument: how hearing loss in later life generates and amplifies further the socioeconomic inequalities in later life. I'm really proud to have discovered the answer to a 40-year-old question as to whether hearing loss directly causes depression. There were many studies the last 5 years, and all these studies were summarized in a systematic literature review and meta-analysis published by Lawrence et al. In 2020. And that study revealed that the existing literature, the existing evidence regarding the association between hearing loss and depression is conflicting. Looking more carefully, I discovered that the previous studies did not focus on the psychosocial mechanism implicated in this relationship. So the findings were conflicting in the last 40 years because actually the studies were examining samples of participants of a different socioeconomic position without controlling for these variables in their analysis. For example, in studies with affluent participants, people that are higher in the social hierarchy, the relationship between hearing loss and depression was weak. On the other hand, in studies with participants of a lower socioeconomic status, the association was significant. You can understand that when a person has a low socioeconomic position, so many things to look after in life, so many other priorities, issues with daily living, having also hearing loss push people down in the social hierarchy and affects the quality of life differently. So basically that was the actual mechanism, and I analyzed longitudinally the data set of participants of 8 waves, a data set of 16 years of collection from 2002 to 2017. And I used some advanced statistical techniques, which is called structural equation modeling, and allows the identification of causal relationships when two conditions develop in parallel over time, in our case, hearing loss and depression, how these two conditions are related to each other. I found that the relative risk for depressive symptoms was 40 to 58% higher for those who had reported hearing loss compared to those who did not have hearing loss. And the findings from this nationally representative study revealed that hearing loss affected people differently. This is the important point here. Hearing loss disproportionately affected the quality of life according to the socioeconomic position. So those with hearing loss in the lowest wealth group were experiencing up to double the relative risk of depression compared with those in the highest wealth quintile. In other words, poorer people had up to twice the risk of developing depression related to their hearing loss than those in the highest quintiles. It is the first time that scientists have revealed that hearing loss affects people according to socioeconomic position. And this study identified that socioeconomic pattern showing that the relationship between hearing loss and depression differs according to people's rank in the social hierarchy. That shows that hearing loss may lead to mental health inequalities and leading to multimorbidity in later life. Multimorbidity is a term used when a person has two conditions or more in parallel. And the data showed also that hearing aids had a stronger effect in alleviating symptoms of depression. This is quite promising finding as well, because that was important for those in a lower socioeconomic position. Hearing aids were a support measure and aided the most vulnerable people in society. So people were able to take more control back and keep participating actively in society. This is really important for healthy and active aging, because that treatment in the study showed that hearing aids allow people to keep having well-being and to keep participating actively in society. Hearing loss is not linked to depression. It is linked to many other conditions. As you may already know, hearing loss is the biggest modifiable risk for dementia. And hearing loss is also linked with cardiovascular disease, diabetes, chronic kidney disease. It is tied to threefold risk of falling, is linked to 32% increased hospitalization, and is linked to greater risk for mortality. So we can see now that hearing loss has a relationship with many other conditions that occur due to or with hearing loss. So even if there is no causal relationship between hearing loss and some other conditions, we have another problem here, the problem of communication. Hearing loss is the basis of communication. And when someone has hearing loss and another health condition, has greater difficulty in navigating the health system. Hearing loss affects communication in healthcare settings and affects the quality of care, the whole quality of care, and the management of other health conditions that commonly co-occur with hearing loss. As I mentioned in my introduction, people with hearing loss find it really difficult to communicate with health providers. And very often they are left unclear about the condition and medical instructions for during the appointment. The good communication in healthcare settings is important not only for the patient, but also for the healthcare professional, so as to be able to communicate with the patient with hearing loss about the symptoms, about the treatment, about all signs that may allow them to do an accurate diagnosis. So the problem of communication leads then to issues with adherence to medical treatment, which poses a significant risk in patient safety, especially in polypharmacy. 50 milligram may sound the same as 15 milligram, which is a real issue for a person in later life that may have many conditions and not only hearing loss. So I have argued that hearing loss may act as an accelerator of aging, especially for those in low socioeconomic position. In summary, those in a low socioeconomic position have up to 2 times more likely to have hearing loss, to develop hearing loss, are more likely to remain undetected and untreated, and are up to 2 times more likely to develop depression due to hearing loss. You can now understand how hearing loss poses a significant risk to functional ability that enables well-being in older age. This is the definition of healthy aging. Functional ability that enables well-being. And hearing loss has a major role here and may dramatically affect people's opportunities for healthy and active aging. In summary, in this talk, I presented how socioeconomic inequalities earlier in one's life cast a long shadow and shape hearing health in later life, the socioeconomic inequalities in diagnosis of hearing difficulties, and how hearing loss in later life generates and amplifies socioeconomic inequalities in health in later life. Thank you very much for listening. I'm happy to answer any questions you may have.
Wow. Thank you. Thank you truly, Dalia, for that very just insightful and comprehensive talk. You raised a lot of very important points and considerations for us all, particularly in the context of hearing health. Hearing is ultimately communication, and so having this conversation is just very, very important. Now, as for questions, again, we encourage folks to please type questions in the chat function only. To start things off, our first question is from Mr. Shmuel Yerushalmi, my apologies for any mispronunciation, regarding social equality and well-being. So Dalia, reflecting on his question, would you be able to comment on perhaps the impact of social equality with regards to hearing-related tools and preventative or treatment initiatives?
I'm not sure that I have understood correctly. So do you mean the early diagnosis or the available treatments?
Yes, so just the social equality and well-being with hearing, and I believe how that can impact the path for patients with regards to hearing assessments, hearing treatments, and so forth.
So the most important thing is the early diagnosis of hearing loss. And unfortunately, there has been a misunderstanding that due to the misleading term, age-related hearing loss. So many people have mislinked hearing loss to aging, and denying the early diagnosis is because they don't want to be considered old. This is a key point, and we need to break this stigma around hearing health and understand that hearing loss may happen at any point in one's life. Unfortunately, those in a lower socioeconomic position have the disadvantage of lower health literacy skills, doing things to protect their health. And in many countries, they don't have the resources to seek help for hearing health. For example, in many countries, hearing aids are not covered by the health systems. So, and a hearing aid may cost $4,000, $5,000. So you can understand that for many people, the cost is huge. I think that while we are raising more attention, more awareness on these issues, many people will take more care of this health need, and this will lead to upgrading this as a health priority.
Thank you. Thank you very much for that. In the chat, looking through it now, I see we have a question from Cynthia Stewin. Cynthia, may I please ask you to unmute to pose your question?
First, thank you, Dalia, for this wonderful presentation, a great overview. Can you comment on the research on hearing impairment and cognitive decline?
Yes, thank you very much for this question. This is a really important topic, as there is a link between hearing loss and dementia. There is evidence that those with mild hearing loss are up to 3 times more likely to develop dementia, and those with moderate hearing loss are up to 5 times more likely of developing dementia. However, this association does not mean that hearing loss directly causes dementia. So at the moment, the current state of knowledge has shown several potential mechanisms, for example, regarding the social isolation, that may be a mediating mechanism between hearing loss and dementia, several changes in allostatic load that may be linked with both conditions. The short answer is that we currently don't know the exact mechanism. And it is my plan in the future to investigate further, because this is a really important issue. Many people suffer from dementia, and identifying the mechanism through hearing health inequalities will be a potential mechanism to have preventative strategies, so as less people developing dementia in the future.
Thank you very much, Dalia and Cynthia, for both the questions as well as the answer. Next, we have Frances Wilkinson in the chat, if you would like to unmute for any questions.
Sure. I was just wondering to what extent you think that this difference in hearing loss across socioeconomic groups is due to differences in the noise level experienced by people in their everyday life, both at work and even in their homes.
Yeah, thank you very much, Francis. Totally agree. This is an important modifiable factor, because people in a lower socioeconomic position usually work in occupations with the highest level of occupational noise exposure. And that may explain why we notice differences between the two sexes, between men and women. So 1 in 3 men in England and 1 in 5 women in England, less women, have hearing loss in later life, because traditionally men work in occupations exposed to higher noise. This is being amplified when people have a lower socioeconomic position, don't use preventative measures, or are not being given hearing measures in some occupations, or in case they don't use them for several reasons, because they may think that they will develop hearing loss anyway, so they don't care about that. They may have lower health literacy, which is a common issue among people with in a lower socioeconomic position. They have lower educational status, so they don't understand the many harmful factors in life. They develop a more unhealthy lifestyle with higher levels of alcohol consumption, smoking consumption. All these factors are linked with hearing loss, and also the accumulation of all these factors harms hearing loss. So a person in a lower socioeconomic position that smokes, drinks above the low risk level guidelines, is exposed daily to noise, will definitely have a worse hearing at the same age with compared to a person working in a professional occupation without all of these exposure factors. All of these modifiable determinants are shown in the conceptual model of hearing health inequalities, and you will have the opportunity to read more in the paper that will be in the resources after this webinar.
Thank you very much. May I please ask Nadia Sandor to unmute to ask your question?
Yeah, I'm aware that in the US recently, the FDA has changed their opinion on over-the-counter hearing aids, and that those are now going to be more widely available. Do you have a comment about that in terms of impact on age-related hearing loss?
Yeah, thank you very much for this question, quite timely. The release earlier this month of the Food and Drug Administration regulations for over-the-counter hearing aids will finally expand the options and give options to more than 4 million Americans with hearing loss. So what is being changed now is that consumers may soon be able to directly purchase more affordable hearing aids. At the moment, Medicare provides coverage only for hearing tests. So a person may see an audiologist to be diagnosed with hearing loss, but without having the opportunity to receive hearing aids, which, as I said, cost around $4,000. And this regulation now gives the opportunity to consumers to directly have access to hearing aids instead of having to go through a clinician. This will be important for many companies also to enter the hearing aid marketplace, to increase competition, and hopefully to drive down costs for consumers. And obviously the winners include 40 million Americans with mild hearing loss, and that will have now opportunity to purchase directly their hearing aids. And also for companies that will finally be able to enter and compete in the hearing aid marketplace, and to have innovative solutions, which will be important for all.
Thank you very much. Our next question is from Catherine Klein. Catherine, may I please ask you to unmute to ask your question?
Sure, thank you. This is really interesting. My question is that increasingly younger people are listening to music either through earpods or very loud performances. And I wondered if there is any research to show whether or not they are developing hearing loss at a younger age, no matter what their socioeconomic status is, and whether that might lead to earlier dementia.
Very interesting question. Thank you very much for that. Yes, definitely. According to the WHO, more than 1 billion young people are at risk of developing hearing loss due to recreational noise exposure. So they have distinguished between occupational noise exposure and recreational noise exposure to distinguish between the risks. There are a lot of initiatives at the moment to address this issue, and public health interventions are being developed under the guidance of World Health Organization. The Safe Listening Initiative is going to have several campaigns, media campaigns from early next year in many countries. So you are going to hear more on this issue because there is a lot of attention on this topic at the moment. Regarding the link with dementia, as I said earlier, we currently don't know whether one situation and one condition directly causes the other. So the people who have hearing loss in later life and also have dementia there may be another reason that causes both conditions. So at the moment, we don't know the mechanism. If we identify the mechanism in the near future, because there are many advances in the research at the moment, we will be able to say that it is important to prevent your hearing loss so as to not develop dementia. At the moment, we are a bit skeptical, but definitely preventing hearing loss and preserving hearing loss over the life course is really beneficial for many reasons, for communication and for depression. We currently know that leads to depression, but in general for communication, because hearing is the basis of communication in life.
Thank you very much, Dalia, as well as all of the questions asked. So scoping through the chat, I see, Lydia, you have a comment. Would you like to unmute to comment on your comments if the case?
Hi, good evening. I'm just worried regarding the selling of hearing aid over the counter, because it might lead to not so good fit of hearing aid. And initially, the older persons will be very satisfied because they are happy over the effect of hearing aid. But eventually, they will end up not using it because of the noises, since it is not properly fit. That is one of the things that is happening here in the Philippines. So I was wondering if you have the same problem with regards to hearing aid not fit by an audiologist. Thank you.
Thank you very much for this question. In the UK, where I currently live, there is not that problem because hearing aids are provided for free. So the cost is not the barrier for the patient. However, regarding the recently announced regulations in the USA, there is a problem now, and there are future steps that need to be done. So the FDA got it right with hearing aids as the treatment, but now it is important to update the Medicare coverage, because while older people now may be able to buy directly affordable over-the-counter hearing aids, they need to have the services covered as well. So they need to be able to see an audiologist and to get unconflicted professional service outside of the market on how to manage the hearing loss, how to set properly the over-the-counter hearing aids, because at the moment this is not covered. And in part, there is an important step, but future steps should include that the bills will allow individuals covered by Medicare to receive hearing care support services for free from an audiologist. And in my opinion, the Congress should repeat this impressive act with future legislation to address this gap in the legislation.
Thank you. There's actually also a question from Facebook from Valerie Sash. Thank you very much, Valerie, for posing your question. And the question for you, Dalia, is how would you suggest to get a person with a significant hearing loss and risks of developing cognitive issues to in turn actually wear their hearing aids?
You mean how you would convince?
Yeah, I think this would also go back to stigma. So how would you suggest them and almost encourage the use of hearing aids, particularly in someone who is not wearing them but requires them?
So there is a whole science behind this process about the behavior change. My background is in psychology, and so I would approach this issue from a health psychological perspective to understand what is the reason, the deep reason behind not using hearing aid. There are several models in health psychology. The most known is the COMB, where C is capability, O is opportunity, and C is motivation. These three factors interact to produce the behavior, which is, in this case, is the not use of a hearing aid. So different interventions, different approaches are used if the issue,
My apologies, folks. We seem to be having slight internet issues. I believe, Dalia, you are back. Okay.
Thank you very much. So I was saying that the way to to navigate this challenge would be to go back to identify the driver of behavior and develop the appropriate intervention for that specific person.
Thank you very much, truly. We have time for one more question, and I see that in the chat from Francis Zenoiden. Francis, may I please ask you to unmute to ask your question?
Yes, thank you very much. It was a really enlightening presentation, which I very much appreciate. And of course, you discuss the socioeconomic determinants and impact. I wonder if you would have any suggestions for the best measures people should take to prevent or reduce hearing loss.
Yeah, very, very important question. I have tried to depict all the mechanisms that lead to hearing loss through the conceptual model. So you can see several factors that are preventable earlier in life. The strategies for hearing health inequalities can be in three dimensions: in mitigating, preventing, and undoing inequalities. Mitigating the existing inequalities, so there is an important area in educating the health professionals on how to communicate with a person with hearing loss, how to identify early signs without neglecting this issue, thinking that it's an inevitable accompaniment of older age, as many general practitioners currently think. The second thing is prevention in several stages, in childhood, in occupational settings, with public health interventions, in targeted interventions in occupations with high noise, so as to not to have to wide inequalities further in the future years. And undoing inequalities, this refers to wider determinants of health. So we go back in resources, power, income of older people to have the opportunity to address this health issue along with other health issues earlier in life and have the same opportunities for healthy aging.
Sorry, can I follow up? But there must be situations where there are medical reasons for hearing loss, right? In terms of physical condition. If it's environmental impact, we can treat that fairly easily in the sense that, one should not have loud noises or whatever. But there are situations where there is a medical reason, right? Something that is actually wrong with the hearing mechanism caused by.
Yeah, definitely. However, I was referring to all the preventable cases of hearing loss, as the WHO estimates that more than 60% of the cases of hearing loss are totally preventable. You can understand that having a burden of hearing loss of more than 460 million people at the moment globally, identifying factors that are related to socioeconomic inequality will have a real major impact and will improve the lives of millions of people.
Well, thank you. Thank you everyone for your discussions and the questions and of course, the answers that were had today. I think it goes without saying that everything was very comprehensive and various points were touched. This Global Cafe does cap a very important topic of drawing attention to hearing health in later life with a special lens of the impacts of socioeconomic disparities. And in a few sentences, may I ask you, Dalia, for your key takeaways for today to share with us all, please?
Thank you very much, Roxana. As take-home messages, I would like to say that hearing deterioration is a lifelong process and not an inevitable accompaniment of later life. So understanding this process is really important and an essential step in addressing the burden of hearing loss and the related comorbidities. Depression, as we currently know, that is directly related, and many other conditions. The second thing is that attention is needed to the early diagnosis of hearing loss, no matter the age. As for many people, there may be significant delays in that process for reasons that have to do with structural inequities and not only with personal preferences. So action in the systems level is really important. And the third and final point is that the early detection of hearing loss and the use of hearing aids may not only promote better hearing health, but also enhance the psychosocial well-being in later life, particularly of those in a lower socioeconomic position. This will lead to more opportunities for healthy and active aging. Thank you very much.
Thank you. Incredible. Hearing health is often overlooked, and you truly did an just amazing job, not only highlighting this comprehensively, but also further demonstrating the importance and impacts of inequities on hearing. So I cannot thank you enough for your expertise and time today, Dalia. It has truly been very much appreciated. And in closing, I would also like to introduce next week's topic and speaker. We have Professor Shireen Hussain on the topic of healthy aging and opportunities in the Middle East and African region. Now, prior to signing off, I did want to, however, thank all my colleagues at the IFA who helped to organize this Global Cafe, most particularly Ms. Bruna Swartz and Ms. Luana Colnago. I greatly also thank you, Dalia, of course, as well as all of our attendees for joining us today. Hope to see you all next Friday, and wishing everyone well and a great rest of your days. So thank you.